So if you do make an error, it can take maybe a decade for it to fully manifest. That being said, some people love pediatrics. The fact you can get a child who's like a few years old and correct a spinal deformity or a deformity to their legs, it means you can give that child a lifetime of good health and mobility. And the magnitude of those positive effects is really appealing for some people. And so that's a big draw to it. There's also a good bit of non-operative management in pediatrics. So this could, non-operative management means you could be following up very complex patients who have some kind of syndrome they were born with that requires lots of surgeries over time. Or shown in that picture there's the Posetti method for correcting clubfoot, where you just slowly recast the foot over time till it's straight. And also then there's bracing, such as in hip dysplasia. We have got spine surgery. So spine surgery isn't usually done in an emergency setting, but that being said, when you are doing spine surgery, the stakes are really high. The surgery can be really long in duration, and it can be very difficult as a procedure to perform. Back pain is one of the leading causes of disability, and relief of this kind of chronic pain can be immensely satisfying if you're the surgeon that does it. However, the big thing with spine surgery is you're really close to the spinal cord, and just owing to this fact, serious complications are a little bit more frequent with spine surgery compared to the other subspecialties. So it's a lot, so some people can find that very stressful, but also, as I said, it's very rewarding. Now, the great thing about spine surgery is it's rapidly evolving, and it's often, out of all the other specialties, at the leading edge of research and advanced operative techniques. You have hand surgery. Oh, sorry, I see someone saying to let in some people. Yeah, sorry, I was just letting in a few people into the chat there. But yeah, we've got hand surgery. So hand surgery is the more cerebral and precise of the other subspecialties. Given the complex anatomy of the hand, surgeries will often require microscopes to visualize the nerves and tendons and vessels. Operating at such a small scale requires a manual finesse that isn't seen to quite the same level in the other subspecialties. And it also requires a very detailed knowledge of a complex area of the body. The workload is varied, really varied in fact, and it can include trauma, congenital defects, overuse injuries, degenerative diseases, and nerve compression, such as in carpal tunnel syndrome. Then, did that come up there? Sorry. Yeah, and then you've got foot and ankle surgery. So this is sort of the hand surgery in terms of complexity, but here the focus is on much bonier structures rather than the soft tissue of the hand. The field is relatively new compared to the others, meaning it has great potential for growth if you want to get involved at a field in its earlier stages. A lot of the work you do is outpatients, but just because the work you're doing is outpatients doesn't make it the pathologies you treat any less serious or debilitating. Trauma in this area is a very big challenge to manage, especially calcaneus fractures and Les Frank injuries. Outside of trauma, foot and ankle surgeons are also involved in the management of post-traumatic arthritis, bunions, and diabetic foot. So the next one is orthopedic oncology. So primary bone cancers in general only represent about 0.2% of all cancers. And what this means is ortho-onc is a really niche and really small subspecialty. In Ireland, there can only be a few orthopedic surgeons who specialize in this area. And whilst the work you do will be to resect the tumor, it does have an element of reconstruction to avoid a subsequent pathological fracture. Orthopedic oncology is also really important to have teamwork, as a lot of your time will be spent in MDTs with radiology, pathology, oncology, and radiation oncology. We then got sports medicine. So if an athlete needs to see an orthopedic surgeon, it will probably be one that specializes in sports medicine. But that being said, if you are specialized in sports medicine, you'll treat every kind of patient. The focus is on soft tissue injuries involving ligaments and tendons especially. And common pathologies you might see would be tear of the meniscus, ACL, or rotator cuff tear. Common procedures you do might involve arthroscopy or even arthroplasty. And a great draw or sports medicine is it allows you to be quite a generalist. And so the next specialty I want to talk about is trauma and joint reconstruction with Mr. David Kealey. And if you could be really kind and just introduce yourself, just who you are, where you're working, and what you do, please.
Can you hear me? My name is David Kealey. I'm a consultant orthopaedic surgeon based in Belfast. I undertake fracture surgery in the Royal Victoria Hospital in Belfast, and my elective practice is based in our elective unit in Musgrave Park Hospital, which is also located in Belfast.
Thanks very much. So just to start off, we've got some questions coming in the chat, but I just want to start off with a few general questions. So when you were a medical student or trainee, what was it that inspired you to go into a career in orthopedics?
Well, certainly as a medical student, I did tend towards a surgical career. I was fairly happy in my own mind that surgery was the way that I wanted to go. At the end of my houseman's year, which was the first year out of university, I applied for an anatomy demonstrator job, which I got. Now, that is a job whereby throughout the course of the day, you teach medical students in the cadaveric lab at university, and it gives you an opportunity to study for the first part of the surgical exam. So for a year, I taught medical students and worked in an accident emergency department and got the first part of the surgical exam in London. At that, I mean, from then I went into the Belfast surgical rotation and rotated around different specialties. And I had early in the surgical rotation attachment and fractures, which appealed to me. I like the theory of it. I like the practice of it. I like the practicalities of it. But I have to say, I also enjoyed pediatric surgery. And whenever I was training, I initially felt that a role going down the pediatric orthopedic route would be best suited for me. It's not where I ended up, but that's what I felt at the time.
So it's kind of when you started your basic surgical training that you sort of made up your mind after getting exposure to each of the specialties? Yeah. Okay. And
I think certainly I felt from the start that I would be a surgeon. What branch of surgery I would encourage a lot of folk not to jump in. I mean, you take some time to feel what is the most thing that's suited to your skill set.
Okay, thanks. And now that you are an orthopedic surgeon, how is your initial impression of the field changed, and what bits do you now like the most about your work?
I think without a shadow of a doubt, whenever I first obtained my consultant's post, it was a much more general approach to trauma and orthopedics. Orthopedic surgeons were, as the word suggests, general orthopedic surgeons. I did hands, I did feet, I didn't do spine, but I would have done arthroplasty. So I did the full gambit. And in my time as a consultant, which is now in excess of 20 years, the actual specialty has become much more refined. I don't think there is such a thing anymore as a general orthopedic surgeon. I think folk come out now with a training and as you've outlined, a subspecialty. So they will get appointed as a consultant orthopedic surgeon with a specialist interest in shoulder surgery. And that has been the biggest culture shock for me going through, is it's become a much more diversified and refined specialty as opposed to the generality it was whenever I first came through.
Okay. And a lot of your work, just in terms of your specialty, so you started off being a generalist, but now you work in trauma and lower limb arthroplasty. Would that be fair to say?
Yeah, my job would be more skewed towards the trauma side. Yeah. With regard to lower limb arthroplasty, as you outlined, hip, knee, and ankle would be the three that people would practice, ankle predominantly, if not solely, by the foot and ankle surgeons. There are those consultants who are appointed for arthroplasty, most of whom would have a primary hip and knee practice, and some may have a revision practice. A lot of folk are stymied by access to theatre, so my consideration was, to me, hip replacement surgery is the gold standard. I think one of the great draws of orthopedic surgery, as you alluded to, is this ability to relieve pain, restore function, and increase someone's independence. And there's no doubt in my mind, the number one operation for that worldwide would be a hip replacement.
Okay. Would that be fair to say, would that be your favorite procedure to do?
It's certainly a very enjoyable procedure. It's a very rewarding procedure, and it's a procedure whereby you see a very rapid response from the patient. I enjoy trauma. I enjoy the excitement of trauma. I enjoy the challenges of trauma, because every time you walk into the trauma unit, you're faced with a different challenge. Every fracture behaves differently, and I enjoy that aspect. It brings variety, it brings refreshment, it brings new experiences. But in terms of an operation, if you want bang for buck, the best one that I would think you could do is a hip replacement.
Okay. And just a question about the work. What is the work environment and culture like in an orthopedics department?
It's very difficult, Adam, to generalize about that. Certainly, I can only speak from my own personal experience. And the Royal College, or the GMC, carried out a review of the trainees in the Belfast orthopaedic rotation, and the rotation scored very highly. The orthopaedic rotation that we have is very well versed in training individuals to get them through the training program. I would like to think that the majority of orthopedic surgeons are approachable, open. We have a good reputation as being good trainers. But I think every unit you go and work in, you will find there are individuals who are approachable, and you will find that there are individuals who aren't.
Okay. And just my next question, I want to take one that was sent in to me beforehand, but it's also come up in the chat. And it's about women being involved in orthopedic surgery. And just to quote this one, it's, as ortho is such a male dominant specialty, do you have any specific advice to females in overcoming any potential gender bias obstacles? Or to be worded differently, how can the world of surgery encourage more females into the surgical field?
I think 10 years ago, that's a very valid question. I think the field has changed enormously. If we consider the north of Ireland, we have 8 female consultant orthopaedic surgeons, and within the Belfast Trust, we have 6 consultant female orthopaedic surgeons. I think within the other surgical fields, the field is changing as well. My impression and my experience is that female trainees are incredibly competent. They tend to interview on the whole better than male trainees interview. They're very competent interview. People always had a fear because of the heavy nature of trauma management that some females may struggle with that, but my experience has not been that. There are tricks of the trade, there's ways that you can use, there's techniques you can use that allow you to overcome any of the great grunt effect of fracture management. So I would say the field is definitely changing. I would not find any reason whatsoever to encourage a female not to train within orthopedics. And if they are worried about the heavy nature of fracture management, there are always ways and means that you can work around that.
I just want to add to your point there. You actually have an upcoming talk about women in orthopedic surgery. So if any of you were wondering about that question, I encourage you to check it out. It'll be coming up in the next while. But yeah, that was a good question. Another couple questions about the work. So a question about on-call. So how often are you personally on call? And if you were fully trained, like what flexibility do you have and how much on-call you take, or how much elective work you focus on?
It depends what job you apply for and what job you get appointed to. The size of the unit will largely dictate how often you're on call. I'm on call approximately 1 on 10 nights, so every 10th night I'll be on call, and I work 1 on 7 weekends. In terms of working 1 on 7 weekends, we are on call one of the days, and we would tend to go in and do a ward round of the major trauma patients the following day. In terms of the breakdown of trauma versus elective orthopedics, again, that depends on the job you apply for. Within Belfast, the majority of consultants would have a joint practice. Most consultants would have a trauma component of their consultancy, and most would have a corresponding elective component. There's about 7 consultants who are purely based on the elective side.
Okay. And how much of your time would roughly be spent in theatre?
I have 1 all-day trauma list, 1 half-day orthopedic list.
Okay.
Some consultants will have an all-day trauma list and an all-day elective orthopedic list.
Okay. And then from first year medical school to now, what stage of your career did you find the most challenging and why? I
think you'll find most things are challenging at some stage. Being a final year medical student at the time seemed terrifying. Being a houseman seemed absolutely terrifying. I think as you proceed through a surgical career, whenever you make each individual jump from medical student to foundation doctor to core trainee, there are challenges that are faced with that. From my own personal point of view, I found getting to be a senior trainee and having to sit exit exams, I found that quite stressful. As a young family and trying to study for exams wasn't particularly easy. But probably collectively, the first 6 months as a newly appointed consultant, I found those the most stressful, because eventually and finally the buck stopped with me. And whilst being a trainee is difficult, the buck doesn't stop.